Start.
Good evening, ladies and gentlemen. Assalamu alaikum. I would like to welcome you all to our new webinar in the General Dental Practitioners series that has been organized by the Hamdan bin Muhammad College of Dental Medicine, part of Muhammad bin Rashid University. My name is Dr. Iyad Hussain, and I'm an assistant professor in pediatric dentistry. And I would like to kind of be the moderator and your guide for today's presentation. And I would like to introduce to you the speaker. Prior to that, I would like to just kind of highlight to you what we do at Hamdan bin Muhammad College of Dental Medicine. We offer 5 masters in different specialties in pediatric dentistry, endodontics, orthodontics, prosthodontics, and periodontology. These 5 programs are 3-year programs that have research, didactic, and clinical components to them. And these programs are recognized and accredited by many global and regional organizations, such as the Royal College of Surgeons of Edinburgh in the UK, the Ministry of Health in Kuwait, the Ministry of Health in the UAE, the Jordanian Board, the Royal College of Surgeons of Ireland, and in Bahrain as well. So these colleges and these courses have been accredited by many organizations around the world. Next slide, please. The timeline for the admission to these master's programs for the upcoming academic year 21-22 is, as you see on the screen here. The applications open on the 15th of October 2020, so they've already, so that should be 2021, I'm assuming, and the applications close in March 2021. So the applications have closed, and the unique thing that this college offers is a special residency program that is separate from these master's programs, and this residency program is in endodontics. And this is for 2021-22 program year, and the applications were open on 24th of this year, and they've closed in March 2021. Now, this specialty residency program has been accredited by, and it's the first one in the UAE. Next slide, please. It's the first one in the UAE that has been accredited by the Saudi Commission for Health Specialties, or the Saudi Board. So, and this is the first residency program that has been accredited outside the Kingdom of Saudi Arabia. The duration of the program is 3 years, and it will commence in October the 1st, 2021. The graduates will be considered specialists with Tier 2 qualifications, and they can apply for a consultant title after completing the required number of experience years. So we'd like to kind of welcome people who've joined this presentation today, and the title is Combined Fixed Removable Prosthesis, Telescopic Prosthesis. And the presenter is a very well-known speaker and a dear friend, that is Dr. Moosa Abuzayeda. He is the program director and associate professor of prosthodontics here at HBM CDM in MBRU. Now, Dr. Moosa Abuzayeda has a fantastic bio profile. He's currently an associate professor and a consultant in prosthodontics at MBRU, and he's a diplomate German board specialist in prosthodontics from DGZ Pro Germany. He obtained his doctorate degree, Doctor Medical Dent, in the year 2000 from RWTH University in Aachen, Germany. And he subspecialized in oral implantology at FSU University in Jena, Germany. And he also holds a certificate of medical education from Kiel in the United Kingdom. Dr. Abuzayeda worked as an assistant professor at RWTH University in Aachen, Germany, and he was appointed as a consultant in prosthodontics and oral implantology at Dubai Health Authority. His main interest is in the field of mixed removable restorations, aesthetics, dentistry, and oral implantology. I leave the floor to my colleague, Dr. Moosa, and I thank you for your attention.
Many thanks, Dr. Iyad, for your kind introduction. Good evening, everyone. I'm so glad to be with you today in this CPD event to present an interesting topic about the fixed removal prosthesis and the telescopic prosthesis. I'll start with some facts about the partially edentulous patient from the American Academy of Implant Dentistry. The number of partially edentulous patients will continue to increase in the next 15 years to more than 200 million individuals, and more than 30 million Americans are missing all their teeth in one or both jaws. Coming to the basics with a classification of partial edentulous arches, according to Kennedy classifications, it is divided into 4 basic categories, which is Kennedy Class 1, the both side shortened dental arch or free end saddle, the Kennedy Class 2, which is unilateral shortened dental arch, and Kennedy Class 3, either unilateral, bilateral, or multiple bounded saddle cases. And Kennedy Class 4 is a frontal gap across the midline and reaching a frontolateral gap, as you can see in Kennedy Class 4. The most distal tooth gap is determinant of Kennedy basic classification, except in Class 4, as you can see here on the right-hand side, that this case we are going to consider the most distal gap, which is the free end saddle. That's why we considered a Class 2 with modification 1. The classification of removable dental prostheses can be classified based on the wearing period, or classification based on the technical design and material, and a classification based on the functional perspective. Starting with classification based on the wearing period, we are having the transitional prosthesis, either interim prosthesis or immediate prosthesis, and the definitive prosthesis. As you can see here, definitive prosthesis here in this case was the telescopic prosthesis, and on the left side it was the immediate prosthesis immediately after extraction of the upper molar teeth. The classification based on technical design can be classified to cosmetic chrome cobalt prosthesis with precision attachment, telescopic prosthesis, or acrylic prosthesis. Here we can see an example of acrylic partial denture as immediate denture here in the upper jaw, or it can be transitional denture in cases of pre-prosthetic treatment where we need time to finish the restorative work before the definitive prosthetic rehabilitation and to finish the periodontal therapy and endodontic therapy. So we need to restore the function and aesthetic temporarily till we get the stage of the definitive prosthesis. The second type is the cosmetic chrome cobalt partial denture as definitive restoration for partially edentulous patient with bounded saddle or free end saddle. As you can see here in this case, it is bounded saddle in both sides. It was restored with the chrome cobalt partial denture, and on the right hand side, tooth number 4 with surveyed crowns. Coming to the third category, which is our topic today, is the combined fixed removable prosthesis with a precision attachment. It is mainly to restore Kennedy Class 1, the bilateral free end saddle cases. As you can see here in this clinical case, it is bilateral Class 1 free end saddle, and it was restored with a front bridge with extracoronal attachment. Coming to the functional classification of the removable dental prosthesis, according to the type of tissue support, it can be classified to periodontal or dental supported removable dental prosthesis, or combined periodontal and mucosal supported removable dental prosthesis, and a purely mucosal supported removable dental prosthesis. In case of purely dental supported removable partial denture, it will be supported by the remaining dentition, as you can see here by the abutment teeth, and the occlusal load will be transmitted mainly to the remaining teeth and their periodontium. That's why we call it physiological support. Here it will be supported by the proximal abutment teeth, and the occlusal load will be transmitted mainly to the adjacent teeth and their periodontium. In cases of periodontal and mucosal supported removable dental prosthesis, it's partially supported by the remaining dentition and partly by the alveolar mucosa. As an example here is the Kennedy class 1 with the anterior remaining dentition. The fixed removable prosthesis, which is our topic today, is a combination of a fixed restoration with a primary retention or friction element attached precisely to the secondary element of the removable prosthesis. In this case, we can see that the primary retention element, which is here the primary telescopic crowns, which is attached and cemented permanently on the prepared teeth, and the secondary telescopes attached on the removable dental prosthesis. The types of fixed removable prosthesis, we can classify them to telescopic prosthesis, the first category, and the prosthesis with the precision attachment, then bar and clip attachment, and ball and socket attachment. The last two groups, the ball and socket and bar and clip, it's mainly used to restore the implant retained and implant supported removable prosthesis. Coming to removable dental prosthesis with the precision attachment, the holding mechanism here is primarily based on friction, and additional retentive element can be installed like activated pins or springs. If it is individually produced in the lab, we call them the semi-precision attachment, and in case that they are industrial produced and ready-made, we call them the precision attachment. Coming to the holding mechanism of the combined fixed removable prosthesis, first is the friction between the parallel walls, and the friction depends on the area of the meeting surfaces and the length of the axial walls. The second holding mechanism is the wedging effect. In a conical bodies, the friction developed only in the final position when we insert the prosthesis in the final position of seating, and this friction will be lost immediately upon release of the prosthesis. The precision attachment are rigid friction elements. We don't use the semi-rigid, we use rigid friction elements, consist of negative outer part attached to the removable dental prosthesis, as you can see it here in the slide, attached to the prosthesis, and the inner positive part, which is form analog, attached to the fixed dental prosthesis. The advantages of precision attachments are good aesthetic result in the anterior region, since it's a metal ceramic restoration, the high patient comfort, and very good retention. An example of the precision attachment is the partial sleeve attachment. We're using here the parallel mill technique. The cemented crown sleeve or the partial crown inner part will be partially engaged from the outer part of the prosthesis. An example for that is the RS attachment, a groove and shoulder attachment, where you can see here the groove and the shoulder, or the groove, shoulder, and extracoronal attachment. Here we can see the groove, shoulder, and extracoronal attachment. In case of a groove, shoulder, extracoronal attachment, the cervical step or occlusal shoulder provide a definitive end position of the outer part of the removable dental prosthesis. Coming to the second type of fixed removable prosthesis, which is telescopic prosthesis. or what we call the double crown system, consists of inner crowns cemented on the abutment teeth. As you can see here in this clinical case, the both canines and premolar are cemented definitively with permanent cement as the primary crown, and the outer crown will be attached to the prosthesis. Both crowns fits precisely, providing support and retention to the removable prosthesis. The telescopic crowns are friction fit component used as integrated support, retentive, and reciprocal elements for removable partial denture. So it will be easy to design the removable partial denture. The indications for telescopic prosthesis are treatment of long span bounded saddle cases with reduced number of abutment teeth, anterior bounded saddle where aesthetic is required, insufficient retention of chrome cobalt metallic partial denture, periodontally affected teeth with reduced prognosis or what we call the guarded prognosis, a treatment of free and saddle cases. Here an example of long span bounded saddle cases with reduced number of abutment teeth. Here we can see the long span from tooth number 1-2 towards 1-8 here. And on the other side, we're having the multiple gaps. So here it was one of the indication for the telescopic prosthesis. The anterior bounded saddle cases combined with posterior free end saddle. Here we're having the anterior gap and combined with the bilateral free end saddle situation here. A third indication, periodontally compromised teeth with guarded or reduced prognosis. The advantages of telescopic prosthesis: high patient comfort, axial loading, so the load will be transmitted through the long axis of the tooth since it's full crown. It is integrated of support, retention, and reciprocal function in one element. It's easy for addition, simple to maintain, good oral hygiene, easy to design the partial denture. The disadvantage of telescopic prosthesis are it needs high technical skills. Sometimes the aesthetic result is not ideal in the anterior region since it's double crowned. The types of telescopes based on the crown form. The main type are the cylindrical, which is parallel wall, and the conical telescope. We can see the cylindrical one and the conical, which is the two main type which we are using nowadays in the telescopic retained partial denture. There is also the resilient telescope. The recommended type, either the conical telescope or cylindrical telescope with 5 to 7 degrees convergence. The type of telescopes based on the crown share. It can be full coverage telescopes, open telescopes, and partial telescopes. Here, in this case, we are having the full coverage telescope, as you can see in the lower canine and premolar, which is going to be covered fully by the secondary crown of the removable dental prosthesis. Or we can have open telescope, as you can see here in this case with a ring design. This is indicated whenever we're having limited interocclusal space and we cannot cover the crown fully with the secondary crown. The partial telescope in cases of limited interocclusal space and to make the path of insertion and removal is easy to the patient. Coming now to the treatment plan in a free and saddle cases, where we're having the challenge here. The first treatment option when we are having the free and saddle cases is the shortened dental arch, the SDA, according to the work of Kaiser, Witter, and Woodsman. Restoring the free and saddle with till the second premolar with thin occlusal units can satisfy the function and aesthetic. And there is a lot of scientific based evidence to support the shortened dental arch from Allen, Kaiser, Vetter, and Woodsman. The second treatment option in free and saddle cases is the implant-supported restoration. And the third treatment option, which is our topic today, is the combined fixed removal prosthesis, either using the attachment, as we can see this case on the left-hand side, or the telescopic prosthesis on the right-hand side. When we start any treatment for the fixed removal restoration, we start systematically by getting the chief complaint of the patient, the medical history, past dental history, patient expectation is so important. Does the patient expect us to restore the dentition with fixed or with stable restoration? The extraoral and intraoral examination, and then the required investigation like the radiographs. Gathering all these data, we are coming with the problem list and the diagnosis, and end up with the treatment plan after discussing this treatment plan with the patient. It's important here to get detailed intraoral examination and periodontal charting to get the proper periodontal diagnosis, which is a determinant for the prognosis of the abutment teeth. The radiographs, you can see here the OPG, which will give you an overview, and the periapical radiographs, which will give you more details about the bone level, the quality of the endodontic treatment, and the apical changes, differentiation involvement. It will give you a lot of details. Usually we start our treatment with in terms of prosthesis as acrylic partial denture here. Here we need to complete the pre-prosthetic therapy, like the root canal therapy here in this case. It was done on tooth number 1-3 and 1-1, the caries control, and the periodontal treatment. After this, we end up with the definitive prosthetic rehabilitation. In this case of the attachment case, you can see the case before treatment with the old crown and a chronic gingivitis and localized periodontitis here, and in the lower generalized periodontitis. And you can see after the periodontal treatment and the pre-prosthetic treatment, how the patient with the motivations maintaining good oral hygiene and with very good periodontal health. Coming now to the clinical steps, we started recording the initial situation by taking primary alginate impression and making a study model. And then this study model will be mounted on semi-adjustable articulator using face bow and bite registration. It is important in this stage to analyze the interocclusal space and to make the diagnostic preparation and the temporary restoration, and to check the occlusal contacts and if there's any occlusal interference. Then we are coming to the crown preparation. It's exactly the same like the metal ceramic restoration. And here we're having the guideline with occlusal reduction 1.5, incisor reduction 2 mm, buccal and lingual reduction 1.5 mm, proximal reduction 1.5. We're using here chamfer width of 0.7 mm in cases of premolars and 0.8 mm in cases of canine, central incisor, and the molars. At the end of preparation, we need to finish and eliminate any undercuts. You can see here that when possible to keep the axial wall of the prepared teeth as much as you can parallel with the path of insertion. The preparation bears which we are using here, for the occlusal reduction we are using the straight Fisher bear. For the palatal reduction of the upper teeth, we're using the American ball. Then we're having the chamfer with rounded edges. For the buccal, lingual, and proximal reduction, we can start the proximal reduction with the tapered diamond bear. Then coming to the after preparation, the final impression. and fabrication of primary telescope. Here the impression, we prefer to take the polyether impression or a silicone, additional silicone. In this case was heavy and light. Then after fabrication of the primary telescopes, we fabricate as well a special tray. And here I want to address this extra step where we're having this pickup impression, or what we call the fixation impression. The primary telescope is going to be tried in the patient mouth to check the fitting, and then it's going to be cemented with temporary cement and Vaseline. And the special tray, we are going to do the border molding in the free and saddle areas, and then we take the pickup impression using polyether impression. Important that there be no impression material in the inner surface of the telescope and no gaps between the primary crown and the impression material, free of bubbles and no pressure area. The next clinical step will be the fabrication, fabrication of master model and bite registration and face bore registration. We know that we don't rely on the working model. That's why we took the pickup impression to produce this master model, which will be more precise according to the position of the primary telescopes in the patient mouth. And here you can see in this case, it was upper complete denture and lower telescopic denture. It's important to ensure enough thickness on top of the primary telescopes to ensure that there's enough space for the secondary telescopes and for the composite facing. Next step is the fabrication of secondary telescopes, the frameworks, and then in the patient mouth we'll do the wax try-in. Here you can see the secondary telescopes with the lingual bar attached with the lingual bar and the wax and the teeth in wax. Here it's important to check the marginal fit between the primary and secondary telescopes. It's supposed to be tension-free seat of the framework. You can ask the patient about the tension or pressure feeling. If he's feeling some pressure or tension, ask the patient to bite 5 minutes on cotton rolls, and you can ask the patient again if this tension feeling is not more there. In the wax trying stage, we need to check the length of the frontal teeth, the midline, the smile line, and the front teeth to be parallel with the interpapillary line. The speech distance, you ask the patient to say 66 Mississippi and see if there is enough speech space. The phonetics, the vertical dimension of occlusion to be checked, the buccal corridor, the tongue space, the aesthetics, and overjet and overbite. In the last stage, we are cementing the primary or inner telescope permanently. Usually we use either a glass ionomer cement or zinc phosphate cement, and we insert the telescopic denture before the final setting of the cement. Here we're bringing the inner crown firmly in position, and the cement rest is going to be cleaned using liquid Vaseline, and then we are inserting the secondary telescopic denture before the final seating of the cement. Then we'll do the occlusal control and we'll check the occlusal contacts. We'll give the patient instruction and the oral hygiene instruction how to remove the denture and to clean the denture and around the telescopic crowns, and giving recall appointment. Here you can see in this case, whenever you're having upper and lower, you can start only with one arch, cementing one arch, and then starting with the upper or lower and then go to the upper, but don't start with cementing all the teeth together. It will be too much and the cement is going to sit and you are not done with the cementation process. The clinical case which I want to show you today It's a cover denture with telescope and telescopes with the chrome cobalt framework, telescopic bridge. Telescopic cover denture here, this 73 years old patient with controlled diabetes mellitus, she was having 3 remaining teeth in the lower arch and upper edentulous jaw. This patient was having, a blade implant supported bridges using blade implants with peri-implantitis, and she was referred from the oral surgery department after removal of this blade implant with peri-implantitis. And then after the periodontal therapy and restorative therapy, we end up with this teeth after the pre-prosthetic treatment. Here in the stage of a trying of the primary telescope and the pickup impression, you can see in the upper jaw, we are doing the border molding using the green stick compound and the black wax in the A line and the secondary impression. The bite registration stage, and then in the final stage, we are cementing the primary telescope definitively on the prepared teeth and inserting the cover denture with the secondary telescopic crowns. Here you can see the upper and lower dentures after insertion, and while the patient is smiling, and you can see that there is nice lip support and very good restoration of the vertical dimension. The second case is a telescopic denture with a chrome cobalt connector. In this case, 65 years old patient presented to the prosto clinic for consultation. He was having, tooth number 3-5, non-restorable, and this patient was having attachment loss and generalized periodontitis on the lower teeth with attachment loss. We started first with extraction of the non-restorable tooth, periodontal therapy. This is the radiographs, the orthopentomogram. This is the case before treatment, and this is the case after periodontal therapy and after preparation of the abutment teeth. And here's the case with the upper complete denture and the lower 4 telescopic crowns. Here I want to bring your attention here that we are having the anterior gap and a free in saddle cases, free in saddle shortened dental arch both sides, and we expect in the future that this patient is going to expected to have an extraction of 1 or 2 anterior lateral incisors. That's why we're having the chrome cobalt connector here. So in the future, it will be easy to add the denture in case of extraction of those lateral incisors. And this is the case after insertion of the denture. You can see here that in the lower teeth, we are keeping the preparation margins supragingival, no need to go subgingival, since it's going to be covered with the lip, and when the patient's smiling, it doesn't show the cervical part of the teeth, and it will be easier to maintain a very good oral hygiene. This is the case before treatment and after treatment with the telescopic denture using chrome cobalt connector. The third case is the periodontally affected teeth with reduced prognosis. As you can see here, patients having periodontally affected teeth with guarded prognosis, attachment loss. After this, the initial situation with the periapical x-rays, and you can see the amount of bone loss around the teeth, and the patient was referred to the perio department, and they end up the periodontal therapy, and it was possible to save 4 teeth in the upper and 4 teeth in the lower, but we expected here, because the teeth have a guarded prognosis, we expect extraction of one or more of these abutment teeth. That's why we decided to go with telescopic prosthesis. So the addition will be easier in the future. And here's the case after inserting the primary telescopes and the upper and lower telescopic dentures with the chrome cobalt connector. This is the case when the patient smiles. For sure that we can see the margin on the tooth number 2, 3, the margin of the primary telescopes, but the patient, the good for giving, things here that the patient was having low smile line. Important when we deal with periodontally compromised teeth to pay attention about the type of occlusion with the lateral excursion, especially here. Here the occlusal concept is the unilateral balance occlusion, or what we call the group guidance. So you're having the contact on the canines, first, second premolar, and mesial side of the first molar to protect the periodontally involved teeth to reduce the load, the load on the lateral excursion. And this is the case before treatment and after treatment. As we said in the start, sometimes it doesn't give ideal aesthetic result in the front region because the telescopic are double crown. The fourth case is a case patient, 60 years old patient after extraction of tooth number 16. You can see here there was a long span bridge with secondary caries under the bridge here. The patient was referred from the treating dentist to prosthodontic department, coming with this situation, asking for a treatment option. For sure that we can see here the marginal gap. The patient was having gag reflex, this is one, and secondly, the patient expectation. She expected to have, a good aesthetic result with the final restoration. She doesn't mind to go with fixed or removable, but at the end she wants to be satisfied with the function and aesthetic. Here, after removal of all the bridges and endodontic therapy on tooth number 11 and 23, restoring them with post and core. Here, decision was to treat this patient with telescopic prosthesis using telescopic bridge here, since the patient cannot tolerate the transitional denture with palatal extension. That's why we decided to go with telescopic bridge in this case. Here you can see the primary telescopes in the model here and the telescopic bridge from tooth number 2.5 towards tooth number 1.3. And we gave the patient here, this U-shape bridge without connector. Usually we like to support the patient with a major connector to prevent the lateral transverse movement of the denture. But when we use this type of construction, we use a very rigid and thick, metallic structure to prevent the lateral movement of this bridge. And this is the case after removal of the crowns and after insertion of the telescopic bridge in the upper teeth. In the upper jaw, you can see here the open telescope, the ring design, since we are having limited interocclusal space. Important here, you can see here on the lateral view that we are keeping a hygienic design in between the telescopic crowns here, so the patient doesn't need to remove the prosthesis, and patient can use the proxy brush in between. But we instruct the patient to remove this bridge daily in the night, clean it properly, clean the abutment teeth and the telescopes. Coming to the long-term studies, the study from Kirschbaum 1987, after 10 years, 10% functional loss of telescopic retained partial denture So it is less success rate compared to the fixed crowns and the bridges. Bergman in 1992, after 5.5 years, 92% survival rate of the telescopic prosthesis. Henners and Walter in 1992, after 5 years, they studied, the telescopic prosthesis using the periodontally affected teeth, and the result was 64 to 67% survival rate of periodontally involved abutment, and 86 to 90% survival rate of abutment teeth with healthy periodontium. Another interesting study from Rehman and Woodsman, the clinical evaluation of teeth fitted with telescopic crowns for retaining partial denture, 7 years longitudinal study of 554 telescopic denture with 1,758 abutment teeth, and the result was 90% survival rate or survival probability for all abutment teeth at 7 years. The most common reason for extraction was tooth fracture. Men's lost abutment teeth at significantly earlier stage than women. Tooth loss occurred earlier in denture with a few abutment teeth, fewer than 3 abutment teeth. And there was abutment teeth loss at an earlier stage if the teeth had been fitted with post and core, especially the casted post and core, and if the patient didn't attend the recall appointment, which addressed the importance of attending the recall appointment. The overall risk of abutment teeth loss with telescopic partial denture should be assessed as low, according to this study. We know now in the implant prosthodontics that we are using the telescopic, as you can see here, to retain the telescopic retained or telescopic supported removable denture. But the question, can we combine in this denture natural teeth, as we can see here on the right hand side, the tooth number 16 and the front 4 implant here. Here it was restored with the, again, telescopic denture using galvanized secondary telescopes. According to the study of Schwartz 2012, survival of double crown retained denture, either tooth implant or solely implant supported 8 years retrospective study. During an observation period of 8.3 years, the superstructure survival was 93.3 for solely implant supported telescopic denture, or what you call the double crown retained prosthesis, and 100% for the combined tooth implant supported double crown retained dentures. Not only solely implant supported prosthesis, but also the superstructure combining remaining teeth and implant within the double crown retained dentures might be reliable treatment option for elderly patient. In this systematic review, I want to address that this case was treated by one of our third-year resident, Dr. Zainab Al-Matairi, and she ended up with nice result with this scientific-based evidence. According to Leon et al. In this systematic review, they found that the estimated overall cumulative survival rate for implant combined with natural tooth in double crown retained removable dental prosthesis was 98.7%, and for solely implant supported double crown retained dental prosthesis was 98.83%. So we can conclude that combining remaining teeth and implant in double crown retained removable dental prosthesis is reliable and predictable treatment modality for partially edentulous patient, and high survival rate and minor biologic and technical complication for both groups, the tooth implant and solely implant supported double crown retained dental prosthesis. Here's the case which is treated in our department. It was referred to the oral surgery department. Implant was inserted by the consultant oral surgeon, Dr. Tawfiq, and the prosto part was completed by Dr. Zainab Al-Mutairi, third year prosthodontic resident at Hamdan Mohammed College of Dental Medicine. Here we can see that we are combining here the natural tooth number 16 with the anterior front implant. Here, after insertion of the telescopic crowns, here the telescopic crowns will be more or less like the abutment. The implant abutment will be milled parallel with the remaining telescope here, or remaining crown. Here we need to use a special jig to bring the those abutment exactly in place. And here we use the galvanized secondary telescope, and on the right hand side you can see the case after insertion in the patient mouth. Here again we made it as telescopic without major connector, but it's important if we want to use this design, the U-shaped design, to have a tertiary structure either of gold or a chrome cobalt. Here, as you can see, the case from the inner surface of the telescope, you can see the galvanized secondary crowns, and you can see the trace of the chrome cobalt connector here. It's supposed to be rigid and a strong chrome cobalt connector to prevent the lateral movement of the denture. And this is the case after insertion in the patient mouth. I want to end up my presentation here with this study from 11 years survival and success of implant and abutment teeth under solely implant supported and combined tooth implant supported double crown removable dental prosthesis. The conclusion was survival and success rate are high for both treatment options. Combining teeth and implant in one double crown retained dentures has no negative effect on the prognosis of the implant. Combining teeth and implant in one double crown retained denture might have a positive effect on the prognosis of the implant and the survival of the remaining teeth. Many thanks for your patience and for attending this lecture. Here is the link for you, please, to follow. And you need to kindly to fill the survey and to follow this link for the credit hours. The credit hours you will get it. The certificates, maybe it will take about 3 to 5 days. Many thanks again, and it's the time for questions or clarifications of the topic. Thank you so much.
Thank you very much, Professor Dr. Moosa, for your fantastically presented lecture and webinar here, which was peppered with great clinical examples and highlighting the beautiful work that you do. And it's very interesting to see these very high success rates for such procedures. I'll open the floor for questions, and I have several questions here. Let me just I'll start reading them out. First, from Mr. Ahmed Al-Habashi, does the use of partial telescopic crowns have an effective retention? So does the use of partial telescopic crowns have effective retention?
Very good question. It have satisfactory retention. It's less than the full coverage telescope. For sure, it will be less it will be more or less like the surveyed crown. It will have the same effect. It will have, and we don't depend on them mainly, but we keep it as extra retention. As you can see in the 2 clinical cases, there was a 3 full coverage telescope and 1 partial coverage telescope. It's a good question. We don't rely on that, open telescope or partial coverage telescope. Mainly, we rely on the full coverage telescope, and those will be as it will add on the retention.
Thank you very much, Dr. Moosa. We have a question from Islam. What is the best method to attach or connect the outer PFM copings to the Cobalt Chromium RPD framework? That's a question from Islam.
Thank you, Islam, for this interesting question. There is multiple techniques to join them. Nowadays, we're using simple technique, which is the laser welding, or if those attachments coming as a plastic, you can include them in the wax up, and it will be casted with the framework itself. This is the 2 main methods to join them with the metal ceramic restoration, either by welding, or you bring them in plastic or in wax and join them in the wax framework.
Okay, thank you, Dr. Moosa. We have another question from Islam again. What is the recommended fabrication method to ensure best fits and adaptation between the inner and outer copings? Wax up, casting, CAD-CAM, galvanized copings, or spark erosion technique?
Excellent question. With all these techniques, actually the answer is within the question. Nowadays we are using the electroplating or the galvano crowns, which prove excellent fit, as we use in the last case. This is one, and you can use. One of the disadvantages of telescopic, prosthesis, that it needs highly skillful technician. Highly skillful technician can produce very well fit by using any of those technique, either by waxing it up or by using the CAD-CAM. Nowadays, even we can use, zirconia telescopic and using galvano on top. This one of the new method, especially that when the patient is removing the denture, especially the ladies, and they can show the golden metallic crowns, which is not really comfortable to them. That's why we're using nowadays even zirconia CAD-CAM primary telescope. But if in that case, we need to use the galvanized electroplated secondary crown.
All right, let me just see here. I am just getting another. Okay, thank you very much from an anonymous listener. Thank you very much. Really nice topic. Question: is there any special instructions for home care?
Yes, for sure. Important that for the patient who's using telescopic denture, to remove the denture once a day minimum, and to clean the primary telescope properly using the proxy brush if they are near to each other, or using the regular brush, and cleaning the denture with a special brush, like nail brush with perfume-free soap and for the denture itself. If the patient would like to sleep with the denture, they can sleep with the denture, but important when they wake up, important to clean the denture nicely and to clean the abutment teeth. Important that the patient is not allowed to keep the denture more than 24 hours out of the patient mouth, especially if the teeth are periodontally involved, because the teeth is going to have micro movement and the fitting will not be easy later. Thank you for this question.
Right. I think we've come to the end. Are there any more questions there coming out? Can I please remind the listeners that you can get your CPD, and it's 1.5 hours, if you can fill the form via the QR code that you see on the screen in front of you, or by following the link. Now, some of you have said the link is not working. Let me just share. Oh, I have another question actually. Another question from Mr. Islam. Can I publish it? Just 1 second. Let me.
Yes, for sure.
I apologize for the too many questions. He's obviously very enthusiastic.
Not at all.
Is the laser welding done after porcelain application or before? And in case of casting with the framework, can the framework with the attached copings be placed in the porcelain oven?
First, the laser welding will be before. Here we don't use actually porcelain. We use you know, a fiber reinforced composite as facing. So it won't be the facing which we use here with telescopic. There is some type of telescopes with ceramic, but it has a special technique and it has a lot of disadvantages. That's why we use the fiber reinforced composite as facing. So the laser welding will be before the before. This is in case of telescope, but if you mean in cases of attachment. In case of attachment, yes, we do it before the. In case of metal ceramic bridges and extracoronal attachment, we join the attachment before ceramic firing.
Okay, I hope that has answered your very interesting, intriguing questions. I'd like to take this opportunity to thank Dr. Moosa again for his fine webinar and very clinically orientated and practical session. I hope you have found this quite educational, as I have. Although I'm a pediatric dentist, I was very glued to the screen watching and listening to Dr. Moosa speaking. We have
many thanks, Dr. Iyad, for your kind words. I want to thank all the audience for attending this webinar and hoping that we will meet with them as soon. Many thanks again.
Thank you. And I just want to remind everyone the link is working. The link that you see in front of you leads you to an evaluation form that you complete. You will receive your CPD in due course. Don't expect it today, tomorrow, next day. Sometime early next week, we'll start sending them out. And on this note, I do have one last question.
Please,
Doctor.
Yes, yes.
And it's the anonymous speaker is: what is the plan for follow-up and maintenance?
Okay. It depends on after insertion of the denture, for example, in the day of insertion, sometimes if you feel that there is reduced retention and the clinical crowns are short, we don't remove the denture in the same day. We call the patient next day after 24 hours. Then we start to remove the telescopic denture. This is one. Then we are giving the patient recall appointment in 1 week, just to check if there's any sore region from the denture and to check the occlusion, and then we keep the patient 3 months and then 6 months recall appointment.
Excellent. Thank you again, Dr. Moosa. I will definitely say finally now I'd like to thank all our listeners and for those who asked questions, and we hope to see you again in our next webinar in the GDP series, which will be usually it's the first Monday of the month, and we'll be delighted if you follow us at MBIU University Facebook, Twitter, Instagram, YouTube. We're all there because the announcements are made on those social media platforms. Thank you again, and I would like to say to you all good night from Hamdan bin Mohammed College of Dental Medicine at MBRU. Thank you again, Dr. Moosa.
Thank you and good night.